It's my pleasure to welcome all of you for our season 5 of the AAP Journal Club webinar. Uh, as usual, we have some international mentors joining on. It's a pleasure to have Dr. Hundscheid joining us all the way from Netherlands. It's 9 p.m. For him, so we're very grateful for him spending his evening with us. And we also have Dr. Slaughter from Nationwide who's joining us, and eminent expert on PDA. So today is going to be a very interesting topic on early ibuprofen for PDA management. And as far as I remember, this has been the most controversial topic. And we are very grateful for Dr. Hanshan to address this topic and for the trainees to learn a lot how to move forward, because this topic is not going anywhere. The equation is not solved yet. So a lot of our future trainees can also pick up the slack from here. So with that, I'll have Maddie Wolf introduce our mentors here.
Great. Welcome, everyone. It's my pleasure today to introduce Dr. Tim Hundscheid, who's a pediatrician neonatologist in the neonatal intensive care unit at the Radboud University Medical Center, Amalia Children's Hospital in Nijmegen, the Netherlands. His clinical and research interests lie in congenital heart disease, neonatal hemodynamics, including extracorporeal life support, and neonatologist-performed echocardiography. He recently defended his PhD thesis entitled Patent Ductus Arteriosus in Extreme Preterm Infants, Prime Suspect or Innocent Bystander. The main project of his thesis was the BeNeDuctus trial, which we will be discussing today. Welcome.
Thank you very much for the invitation. Happy to join.
I have the pleasure of introducing Dr. Slaughter. He's a neonatologist, epidemiologist, and is the co-director of the Ohio Perinatal Research Network within the Center for Perinatal Research at the Abigail Wexner Research Institute at Nationwide Children's Hospital. He's a tenured professor of pediatrics at the Ohio State University College of Medicine and also holds a courtesy appointment in the Division of Epidemiology within the Ohio State University College of Public Health. His patient-centered research program focuses on comparative effectiveness research to determine which treatments work best for neonatal patients, given specific clinical circumstances and patient characteristics. And relevant to the talk today, two of Dr. Slaughter's recent NIH-funded grants focus on the PDA, one being early prediction of spontaneous PDA closure and PDA-associated outcomes, which is an R01, and also he is co-PI of the pivotal trial, which is the percutaneous closure trial that is ongoing. So welcome, Dr. Slaughter. And on a personal note, he was my fellowship research mentor, so I'm happy for him to join us today. So welcome.
Thanks for having me.
Yeah, excellent. And we have Paul Arichai, who's a fellow presenter from University of Southern California, and it's his favorite topic, looking at PDAs. So we are in for an exciting session today. Just some housekeeping stuff as usual. The mentors and the moderators are allowed to interrupt the presentation to raise any discussion points. For any audience who have any questions, please put in the chat and we'll surely go through that at the end of the session. Paul, the stage is yours.
And Meryl is absolutely right. I enjoy looking at PDA, but don't ask me what to do about it. So it's my pleasure today to talk about the BeNeDuctus trial. This is the paper that we'll be reviewing. So just to level set a little bit, the ductus arteriosus is a vascular structure that bridges the proximal descending aorta to the pulmonary artery near the origin of the left branch PA. The ductus is essential for fetal circulation to divert the cardiac output away from the lung to support systemic oxygenation. But after delivery, the pulmonary vascular resistance decreases, so the lungs become the source of oxygenation and gas exchange, so the ductus is no longer necessary. So in a normal term infant, ductus closes in about greater than 90% by 48 hours of life, and about 100% by 96 hours of life. However, in preterm infant, due to the structural and physiologic immaturity, they are associated with delayed closure of ductus or persistent ductus arteriosus at term equivalent age. And based on this natural history study, you can see for those less than 26 weeks gestation, the median age of ductal closure was 71 days. And by the term equivalent age, greater than 25% of them still have patent ductus arteriosus. So in a few cases, the ductus persists even to later childhood or in adult life. So what is the significance of prolonged exposure to PDA shunt? So this is what my hobby comes in looking at PDA using echo, right? So if we assume that normal physiological state where PVR is lower than SVR, the PDA shunt would cause left to right blood flow. Thereby, the QP to QS ratio would be greater than 1. But how much higher? In other words, what is the shunt volume? Well, the only way to determine that would be to use CAS study, but that would be way too invasive for a routine diagnostic test in our fragile, extremely low birth weight neonates. But this QP-QS ratio, even as conceptually, it is important as it determines the severity of pulmonary hyperperfusion and systemic hypoperfusion, leading to in-organ impacts. Many have studies way to estimate the degree of shunt volume non-invasively using echocardiography. I won't get into much technical detail here, but if you follow the flow of blood, you can understand the rationale behind all of these echo measurements. First is the PDA size and the flow profile. This provides a sense of flow through the shunt using Poisson law. However, because PDA has many different shapes, the limitation of using diameter alone is notable. Next, then the blood will flow to pulmonary arteries, which can be measured by end-diastolic Doppler velocity and pulmonary vein velocity. As the shunt volume comes back to the left atrium, this leads to volume loading of the left atrium, leading to enlargement, and that can be measured by LA to AO ratio. And because this volume also increases the preload to the left ventricle, this increases cardiac output. This is also a way for the body to compensate to maintain adequate systemic perfusion. We can also measure the impact on systemic blood flow by Doppler as well. As the shunt has low resistance, it may cause fluctuation in systemic blood flow or flow reversal altogether, which would impair in-organ perfusion. As this one study showed, the failure of PDA closure is associated with increased mortality in preterm infants. So should we facilitate ductal closure? Well, many studies have looked at various ways to medically close PDA in premature neonates. So there are different strategies. One is prophylaxis, which is a treatment of all predefined groups within 24 hours of life. Notably, endomethacin has been used for this. It's been shown to reduce systemic PDA, need for surgical ligation, severe IVH, and risk of pulmonary hypertension, but there was no effect on mortality or neurodevelopment outcome. Second is early targeted pre-symptomatic, and this is really based on targeted neonatal echo, which can detect significant PDA that precedes development of signs and symptoms. This is usually within the first 3 to 5 days of life. And lastly is the late systematic treatment, which provide the strategy here is to allow for possible spontaneous closure of PDA and only treat those who patients seems to have signs and symptoms that may be related to PDA left to right shunt. Now, an important concept here is the balance between risk of disease versus risk of treatment, which we'll explore more later in this paper. The agent used here are NSAIDs and acetaminophen, or our European colleague would call paracetamol. These are medical therapy use. The efficacy of NSAIDs are around 70%, range from 57 to 81%. Acetaminophen's 58%, which range from 27 to 73%. Now, the efficacy also includes the rate of spontaneous closure as well, which may be as high as like 30 to 40%. So the efficacy of the medical treatment itself is in question, and also previous studies have not shown significant benefits on clinical outcomes such as mortality, BPD, NEC, or neurodevelopment. So with that, many centers have shifted towards a conservative approach with expected management of PDA as opposed to aggressive ductal closure. However, and these may include fluid restriction, the use of diuretic after fluid reduction, increased positive airway pressure, using high hematocrits. But the evidence for these expected management is limited. Another issue is that prior to BeNeDuctus trial, preceding RCTs has a really high rate of crossover between the control and the intervention group. Here's to quote Dr. Hundscheid here, there was a substantial part, up to 85% of the control group would actually treat it for PDA. So instead of concluding that PDA treatment does not lead to a better outcome, it can only be concluded that there is no significant difference in early versus later or delayed treatment. So that's the goal of our BeNeDuctus trial here, is to study in among the extremely premature neonates with echocardiography confirmed PDA, and this based on diameter size alone, greater than 1.5 millimeter with left to right shunt. Would expected management be non-inferior to early ibuprofen treatment based on a composite outcome of NEC defined by Bell stage 2A or higher, moderate severe BPD, or death at 36 weeks post-menstrual age. And the non-inferiority margin is defined by 10 percentage points absolute risk difference. And we'll talk a little bit more about what that means.
Dr. Hundscheid, it's a good time to break and just go through you. I mean, so can you walk us through what your understanding of science was and why did you choose to design the trial this way going forward and your experience coming through? Because PDA has been studied for since 1980s, almost 4 decades now, and we're still asking the exact same question, whether it helps or not. So can you just give us your experience?
Yeah, I think as was shown nicely by Paul, that previous studies had a tremendous amount of open label treatment. So I think in our design, we choose to randomize treatment intention rather than do a placebo-controlled trial. So we actually randomized the duct as a prime suspect, which should be treated because the duct leads to a negative outcome. Whether the patient who lies beside that, you should consider the PDA rather as a marker of immaturity. Because that was also shown, I think, by the natural history from Semberova, the paper you've shown with the graph that the duct will close in the preterm infant, but it takes a longer time to close. So is it the extreme prematurity which should be considered as the pathophysiological state, or the PDA itself? And the incubator, which was randomized to expected management, we would really say it's the immaturity itself that is associated with worse outcome, rather than the PDA plays a causal role in it. And I think by randomizing this treatment intention rather than doing a placebo-controlled, and by defining more neutral open label criteria rather than rescue treatment criteria or something like that, which was done in the PDA Tolerate, I think we set a high threshold to have a clinician intention to treat a PDA in patients randomized to expected management. So I think that was really different from the studies that were done prior to the BeNeDuctus trial. And one of the things we did was that in those who were randomized to expected management, we didn't look unblinded, at least in the patients, for the PDA, because that's, I think, one shortcoming of previous trials is that you give placebo, then after 3 days you do another echocardiogram, you still see the PDA, then you will be more eager to treat, rather than when you don't do the echocardiogram, you're not that eager to treat the PDA because you don't know that it's present. That's also a shortcoming of the interpretation of the data, unfortunately, because we don't have that many blinded echocardiograms in the expectant management group. So we're not informed about natural course and the expectant management group that good. But those are...
Yeah, I think these are good points about, and I think we'll discuss more further on this. Paul, you can continue.
Sounds good. So talk more about the methodology of the research itself. So this is a multi-center randomized controlled non-inferiority trial. It enrolls babies from 17 different NICUs in the Netherlands, Belgium, and Denmark. The inclusion criteria is gestational age less than 28 weeks and echo parameters diameters less than 1.5, left to right shunt, and time to enrollment has to be between 24 to 72 hours of life. There's a number of exclusion criteria. Those are contraindication for ibuprofen, which include like having active bleeding, IVH, GI bleed, thrombocytopenia, renal failure, oliguria, or suspect NEC. Or if there's any ibuprofen used before randomization, any sign of pulmonary hypertension with left to right shunt greater than 33% of cardiac cycle, or any sign of congenital heart defect aside from PDA and PFO, and any sign of congenital anomalies, which I think were all really fair. And we have to have informed consent from parents. And then really interestingly, we can talk about this as well, which we use block randomization, where each center at gestational age into two groups, less than 26 weeks and equal to greater than 26 weeks. And we use a variable block size ranging from 4 to 8. I don't know, Vero, I don't know if you want us group to discuss about this design? Or...
Specifically, I'd like to actually ask both Dr. Hundscheid and Dr. Slaughter about the timing of treatment in the experimental group. Like, you know, we can talk about what the data from past trials show, but I'm also curious what your impression was from centers, what they were doing in practice, and how that informs treatment. I know Tim and we've discussed this before, because I think it might be different in the US and versus where the trial was done.
Maybe
Tim, maybe first about from the trial, and then
Tim, go ahead. Yeah.
Okay. In the Netherlands, I think there were two main practices. So there was, I think, half of the neonatal intensive care units that performed a screening somewhere within the first week of life, most of them within the first 3 days of life, and some of them within the first week, and then would treat, well, nearly every duct which was above 1.5 millimeters who had a left to right shunt, which was non-restrictive, versus the other group that never looked at a PDA unless the baby was stuck on a ventilator or there was, signs of congestive heart failure, things like that. So really two groups, I think, and a few NICUs, only one or two. We only have 9 neonatal intensive care units within the Netherlands. So I think one or two of them who were somewhere in between and more on a case by case. And that's why, we had to look at the 72-hour mark, because that's, I think, the really pre-symptomatic treatment group. You could shift it to maybe 5 days of life, but 3 days of life was the chosen cutoff, which was, I think, the cutoff which is used in previous trials also mostly.
In the US, I think we've been sort of all over the map as far as treatment over the years. And, prophylactic endomethacin, which I don't think is as, last time I looked, it was about 30% of units we're using, and I'm guessing the number's probably gone down some, but that was given in the US early on quite a bit in the past. That's changed. I think based on this study and the baby Oscar study as well, I think we're probably seeing less drug treatment in that first week, but I think there's still questions about weeks afterwards. And then there's there's the sites that have hemodynamic training where they'll do echocardiograms and based on the physiology of a specific PDA decide to treat early. And so there are groups that are saying, hey, this PDA based on symptomatology, based on certain signs of PDA, are treating early. And I think the other thing is, and this is something we've seen in the pivotal trial where we've actually had to, we were trying when we came up with pivotal, trying to look at catheter closure in the first month, and we've actually moved it to the first 50 days because there's places that will now do Tylenol, and they'll do that for weeks at a time at some places. My bias is that the drug's going to work. It'll probably work in a shorter time, but there are, there's places doing long-term drug treatment with acetaminophen now, and we don't have the best studies there. I'll let you go back, Paul. But all over the place.
Yeah, one thing that I want to highlight here with the design too, and I'm sure Dr. Hundscheid can talk more about, because we cannot blind the treatment versus non-treatment group per se here. So the block randomization here is critical here to to create a concealed, stratified block to protect from the selection bias, right? And to how to and that design allow to have a balance between the groups. Prevent people from having knowledge of how the next person will be allocated into two groups using variable block sizes too. So I thought that was really brilliant of how it was designed. I don't know if any other comments you want to make on that, Hundscheid?
The only comment I wanted to make is that we really wanted to stratify per center because the centers that were really eager to treat outside the trial, if you would randomize 4 or 5 patients to expected management and they would have a adverse outcome, then they will not be eager to enroll further patients, I think. So by doing a center stratified randomization, you will have like half of the patients randomized to either treatment. And I think that was really helpful in maintaining willingness to enroll patients in the trial.
Thank you. All right, the other thing that I want to discuss about is the concept of non-inferiority trial. So, and the expert here can help us as well. But from my understanding, so this is a graphic that I thought is really, really nice to explain. So if you look at the graph in the bottom here, if you can see my mouse here. On the bottom is the treatment, the new treatment compared to the old. So in this case, expectant management compared to ibuprofen. You can see here, if the new treatment is worse, it's on the left side. If the new treatment is better, it's on the right side. So for a traditional superiority trial, this is what you were looking at, where this the standard deviation and the confidence interval on either side is on the right of the graph here. But for non-inferiority trial, what do you want? The goal here is that to determine if the new treatment is not substantially worse than the standard treatment based on a confidence interval that's not greater than a predefined unfavorable difference in outcome. So meaning if the neutral line is in the middle here, you create a margin of non-inferiority margin. So in this case, we choose 10%. And our goal is to determine if the new treatment is within this non-inferiority margin. And if the one-sided of the confidence interval stay within this margin or not. That's the goal here. Did I explain that okay? I'll leave it to our expert here to explain a little bit more.
Yeah, you did, I think. And what's I think really interesting for a non-inferiority trial is that you do a preset of your non-inferiority margin, because the previous non-inferiority trial on PDA management was by Sung et al., I think published in 2020 or so, in which they set a non-inferiority margin of 20%, which I think is ridiculous if you have a 20% non-inferiority margin for mortality or BPD. But you can also discuss about 10 or 5% what is a reasonable non-inferiority margin. So we chose for 10%, but you can discuss about that also for, well, days, I think.
Sounds good. And that design affects the way that sample size will calculate it as well. And you can explain to us a little bit more here, but the sample size calculation is based on, first of all, we use the Dutch perinatal registry for disease incidence. And that estimates for composite outcome to be around 35% for those less than 28 weeks gestation. And again, we set the non-inferiority margin of 10%. With the one-sided type 1 error of 5%, a power of 80%, the number needed was 564 patients with 282 in each arms. So I know the original estimation was with 540 neonates born per year in less than 28 weeks, with 3% of PDA, we would be able to complete the trial in about 3 years. How did that play out?
Well, that was a bit optimistic, I think. Way too optimistic. Also, the incidence rate was lower, I presume, and the inclusion rate was way lower, which I think had many reasons. COVID was one, of course, but also the practice, because in the center that didn't look at a PDA routinely, you should have informed consent prior to do the study echo to see if there was a PDA. And if there was a PDA, it should be eligible to include. So we lost some patients there. And the overall inclusion rate was about 30% or so. So I think it's a really difficult study to explain to parents because you're not adding something new, but you're trying to put something that is routinely used to the test, and that's really difficult to explain to parents because they will ask you. That's the question I've been asked most doing informed consent procedures for this trial. What would you do, doctor? What do you think is the best treatment? I would say I don't know what the best treatment is. I think it's best to randomize. And I would explain them that if they were not enrolled in the trial, they were actually randomized on zip code, because if their baby would have been born in the NICU of Maastricht, it would have been treated. And if they would have been born in Zwolle, which is a small city in the Netherlands, they wouldn't have a look at their PDA at all. And sometimes that explanation helped parents to say, well, then I think it's best to participate to the trial. But I'm not sure if everybody who did informed consent procedures was that aware of the discussion. If you're somewhere within the spectrum, more or less eager to treat or eager to do expectant management, if you would have been asked by parents, what do you think is best? I think, and we discussed it the previous to this recording about implicit bias, then I think you will, even if you will not say, I think it's better to treat, parents will notice your preference, I think.
And that's a good way to put it. I think in presenting, and I've done this with Pivotal and consenting parents too, it's really that where your baby is born and whichever doctor is taking care of the baby really has an impact on whether the baby's treated or not, because we as a group just can't decide. I think, at one center, we might do it one way, or and we've got in our trial, and I'm sure your trial, you were saying the same thing, where you have different centers that tend to do one thing or another, but trying to explain of the reason we're doing this is because clinicians around the world really don't know the best answer, and we have to pick one. So it's a good way to present it.
That's great. Thanks for sharing your experience. That's really important. All right, and then we also did intention to treat analysis as well, per protocol analysis. We also looked at the exploratory subgroup analysis as well, and for sensitivity analysis. And there was also a data safety monitoring board to do interim analysis at 4 different time points as well. So in terms of the methods, so first, after enrollment. So first, we would have echo done initially between 24 to 72 hours. And those who meet the gestational age and PDA diameter and have informed consent done would then be randomized to either expectative or expectant management versus ibuprofen treatment group. For those under the ibuprofen treatment, which again is really the control here, would be treated based on the local protocol. And they will have echo confirmed at greater than 12 hours after the last dose, and they will continue to get treatment until the PDA is closed or ultimately have a ductal ligation. Versus on the expectant management group, no intervention was done, but everyone would have a blinded echo performed at day of life 6 to 8. And these were done by pediatric cardiologists who can read the echoes, again, blinded to the neonatologist and the treatment. There would be an open label consideration if for pre-specified criteria. And this is the pre-specified criteria based on the echocardiography. And it looks really long, but essentially, basically what I present at the beginning about the echo parameters. Of note, these are really restrictive. So these are all so which is a really restrictive criteria from my experience. I don't know how many babies I've seen fulfill all of these criteria. But that's explain how we have a really clean study with this group, and not a lot of people will fulfill this criteria needing treatment. So this is the definition for BPD in NEC. The BPD is based on Bancarelli definition for the needs of supplemental oxygen or positive pressure ventilator support at 36 weeks post-mental age or after at least 28 cumulative days of supplemental oxygen. And NEC is based on Bell stage criteria. All right. So in terms of results, so the studies continue from December 2016 to December 2020. We had 1,600 infants screened. 1,344 parents were notified about the trial. Of those, 442 had an informed consent. So that's about 33% consent rate. And of those, 273 actually underwent randomization. So about 62% randomization rate. So overall inclusion based on the number of people who were notified until number of people randomized was around 20%. All right, after randomizations, half of the group were randomized to expectant management and the other half to ibuprofen. One thing we want to highlight here is, again, to highlight how clean the data is. Only one of those who randomized to expectant management had received an open label treatment. And the same token, only 2 who randomized to early ibuprofen did not receive ibuprofen. So again, this is to fulfill some of the gaps in research that was done before this trial. I'll just skip that. In terms of patient characteristics, please let me know also if you want to pause at any point. But
I just wanted to say that's amazing. Like, that's wonderful, awesome for the trial group that did the study, Tim. Like, to have not a lot of crossover, so, or people receiving the randomization. So just in a contentious topic like this, I think it's good. So
yeah, and I think it helps that it's well, it is multi-center, but we have a good research network in neonatology in the Netherlands, which every NICU has a representative, and each I think 2 months they meet, and then you can keep them updated on the data, keep them informed on previous trials, and keep pushing the open label should be prevented. And also many thanks to Willem, of course, as PI, which was phoned, I think, many times to convince people not to treat within the expected management arm. So it's not only putting up a good study protocol, but also being available for discussion whenever there's a question in the clinic.
Tim, could you speak to when Paul showed the criteria for considering treatment, which I think was the criteria to unblind the echo? Is that right? Like if they met all of those, that's when the clinician would be informed of the echo results. Is that my understanding? Correct?
No, unfortunately, the unblinded echo, which was in the study protocol intended for all babies randomized to expected management, there's only, well, we have to analyze that data, unfortunately, still, but I think it's something like half, or if it would be half, it would be many blinded echoes in the control group. So it was really if there was a clinician intention to perform an echocardiogram, and I think there were 5 echoes performed in an unblinded method.
Gotcha.
Yeah.
So very few, I guess what I was speaking to was people knowing a PDA was present and actively choosing not to treat, or were they actually just not echoing because of, you know,
it was
trying
mainly
to think about avoiding the question at all.
Yeah, that's I think the takeaway. They were not looking at the PDA, and there's one echo that was unblinded. That was a baby who got a coarc, developed the coarc at day 7 of life, which was seen on the blinded echocardiogram, which was of course discussed with the clinician team. So that was a interesting finding.
Sounds good. All right. So let's look at our characteristics of the cohorts here. So I think on the most part, the between the two groups are pretty balanced. The only thing I would just point out, I think it's really representative of the populations at the sites, which are predominantly white, about 80%. The maternal characteristics are very similar. The neonatal characteristics, the only thing that I saw was the median birth weight were a little bit different between the two groups here. But everything else were similar. And the primary outcome, again, is the composite outcomes of neck, moderate to severe BPD or death. Really significant. There's expected management group 63%, early ibuprofen 87%, with the absolute risk difference of -17%. And most of these is really due to BPD rather than neck or mortality, although there is also a difference in mortality as well. But most of the effect is based from the BPD. And I know this is meant to be non-inferiority trial, but I'm just playing around with this absolute risk difference. If you calculate the number need to harm was 6, so which is quite significant. I'll just pause here, and I'm sure people would have comments on this.
Yeah. With that, Dr. Slaughter, since we have a lot of trainees on this session, do you mind giving us a quick overview of difference between a per protocol intention to treat analysis and benefits and drawbacks?
So intention to treat is whenever a baby is randomized. So in this case, a baby is randomized to expectant management or receiving ibuprofen. You do the analysis as if the baby received what they were randomized to. So say a baby is randomized to expectant management and they actually get ibuprofen, you would still analyze them as having received expectant management. Per protocol is where you analyze based on did they follow the protocol. So you would analyze those babies in expectant management, they got expectant management, and those in early ibuprofen that got early ibuprofen. And the reason for intention to treat is to prevent, it's really to prevent bias from people actually crossing over and doing something. So it's actually a way to get around a bias that you would see from people not giving the assigned treatment. Per protocol, so there's benefits to both. Intention to treat, we think, that's the one that most of the time we go with as a final in a trial that people want to see as the final trial estimate. But doing per protocol is a good idea as well, so you can see the difference. And just think of other studies. In this study, I think the differences weren't that there weren't these huge differences because there really wasn't. Most of the babies randomized to expectant management got expectant management, and ibuprofen got ibuprofen. But thinking of studies, especially wherever I think of, especially studies in adults where you randomize someone to some sort of intervention where they are supposed to do something and they don't, and then you're getting an idea of in a study how much does actually giving the people this, assigning them to say they're supposed to get this intervention help versus how much does it actually help if they followed through and did it. So it gives you two different estimates: getting assigned to receive the treatment and if you actually followed through and got the treatment. But there's some bias in taking out those babies and only doing per protocol. You're eliminating some babies and causing some bias, if that makes sense.
Yeah, that's helpful. On staying on the same topic, so with the results, Dr. Slaughter, were you surprised with the results, or given the past understanding of the literature we have?
I was, so I've always been looked back at, Dr. Bennett's had put together meta-analyses and people looking at the past studies where no one has ever, there were PDA studies where people's primary outcome was, did the PDA close, yes or no? And with those studies doing meta-analyses, people looked at some of these other outcomes and really never had found a difference. So, and I had done some observational research and instrumental variable analysis trying to use some variation and didn't, in all babies with PDA, didn't find a difference. So I guess I've been a skeptic of treating all babies with PDA, if that actually helps. So, but I think the one surprising thing here was the result that possibly that you might have an increased BPD if you get treated with drugs. And I don't think we were expecting that as a possibility. And I know the way the trial was reported, it was a non-inferiority study. And so, but when you do the study, or whenever you go back, and I did the numbers as well, looking at the study, when you go back, actually showing that the drug ibuprofen actually seems like it may be harming babies if they're getting it in the first week. I think that was unexpected, but actually eye-opening. So I think this study shows that, hey, we shouldn't be treating all babies with PDA. And I think that's a question we can talk about later is, are there any babies with certain severity of PDAs that should get treated? And I think that's a different question, but all babies with PDA, it seems like there's no benefit. The baby Oscar study had a similar result. All babies being treated with ibuprofen doesn't seem to help, but there's actually potential harm here. I think, that would need to be, well, I shouldn't say explored further because we don't want to do a study to look for harm, but it's as people get other studies put data together, that's something to worry about. But I think as a treating physician, I think, hey, if it's not helping, and there's a possibility of, I probably wouldn't do it, but especially if there's possibility of harm, it makes it even more worrisome to treat.
Dr. Hundscheid, do you want to comment on the results of the study, how when the results came?
Yeah, I think it was unexpected because otherwise we would have designed a superiority trial that it was better to do nothing. And we didn't conclude superiority because that's, I think, a discussion or you can have with the trial statisticians. Our trial statistician concluded that you intend to do a non-inferiority trial, but if you look at the data, you can conclude superiority on your data. But the trialist statistician from the New England said, well, you did a non-inferiority trial, so you should be clean in reporting non-inferiority. And we didn't choose to put the battle and publish in the New England. But I think looking at harm, because we included about 48% of the intended power, if we would have gone to the 50% data safety monitoring board, I think they would have stopped the trial due to potential harm. Well, we will never know, of course, because what would have happened if we would enroll, I think, 5 more babies and we would have got the data safety monitoring board come together. But that would be, well, we weren't aware of the previous analysis at 25% enrollment. But later on, we heard that there was also some signal there already at 25% of enrollment. So I was surprised. But if you look at the pathobiology and if you dig further into it, and having thought about the prostaglandin pathways and things like that, and not giving effective treatment, but intervening in other pathways like vascular growth factors, I wasn't that surprised anymore, I think, because the equation of PDA and outcome is not simply PDA is outcome, but it's PDA which is not effectively closed after ibuprofen, because I think it was only 55% after one course and 74 something like that after 2 courses of ibuprofen. So not getting PDA out of the equation in all babies and maybe adding some unknown variables to the equation doesn't lead to another outcome.
So, Dr. Slaughter, a quick question for you before we move on.
Yeah.
So, is it kosher for us to interpret this data in terms of superiority analysis, even if it was not predefined?
I think, I think mostly, I think non-inferiority is where we should really, it was predefined. I think we know the data are there. And so I think reporting the way it was reported in the New England Journal was the correct way. But I think we can't say 100% is what I should say is, like, we can't say for sure from this study that ibuprofen is harmful, but it is worrisome. If it's not helping, there is a possibility that it could be harming. And that's the way I like to say it until more data come in.
Sounds good. Thank you so much.
I will add, to Tim mentioned the Sung trial earlier when he was talking about non-inferiority and margins. And I will add, while that trial was half the size, the effect estimate was higher. There was a higher incidence of BPD or death in the treatment arm in that trial as well. So I don't know if when you guys were planning it, if you had considered, thought about what they had seen, because I know their center had stopped treating and also saw observationally before their trial that, rates of BPD or death decreased when they started doing conservative management. And then they did a trial and they saw a similar, not significant, but a similar difference. So I don't think it came out of complete nowhere. But I still think the number needed a harm of 6 is, powerful.
Yeah,
pretty powerful. Yeah.
Yeah, one of the main shortcomings of the study by Sung is they only published their per protocol analysis. So I think that's also what the Baby Oscar trial did. If you exclude those babies that were treated open label with ibuprofen, you exclude the sickest babies, because you wouldn't treat with ibuprofen after enrollment to expected management if the baby's doing fine on CPAP, 30% of oxygen. And you might treat if they're stuck on the ventilator, suffer from gastro retentions. So if you exclude those babies from the expectant group, then that group will do better, because you exclude those who have associated risks. So that's, something I've tried to contact the authors about what the whole cohort was about, but never got a reply, unfortunately. So I would be really interested about their intention to treat analysis and how many babies would be analyzed in that protocol.
That's some really good evidence-based medicine points of how to interpret literature, just looking at the trial design and various biases rather than just at the results. Paul, you want to finish up your slides?
Sounds great. So let me talk a little bit about the secondary outcome that you look into as well. So there's a lot here, but I'll just point out the death at 28 days were different between the 2 groups. The pulmonary air leak syndromes were also different. With, again, both of these early ibuprofen groups will have higher incidence of. The other interesting thing is the paracetamol, so acetaminophen exposure, they were higher on the early ibuprofen group as well, which I'll have Dr. Hundscheid to point out. And the only thing that the time until full feeds were about higher in the early ibuprofen group by about 2 days. But the only thing that I also want to ask about is the number of days on supplemental oxygen were not different between the two groups. Even though in the primary outcome, the rate of BPD was the one that we talked about, it was significantly different between the two. So want to clarify, even though there are more BPD in the ibuprofen group, but there's no difference, and why is that?
To start off with your final question, it's the median presented for the supplemental oxygen, and also the interquartile range didn't differ. One of the shortcomings of definitions is that we use the BPD classification of Bancalari rather than, for example, the Jensen criteria. We also looked at that for stage 2 or stage 3 BPD, and well, it was not minus 17.6, which was in the primary outcome, but I have to look it up, but it was something like minus 12.8, something like that. And that's also one of the sensitivity analysis we did, because many babies who are on CPAP at 36 weeks of age without supplemental oxygen are also considered severe BPD, which I don't think is like a parenchymal lung disease, but more preterm or premature breathing pattern. But even if we exclude those babies from the sensitivity analysis, there's still at least non-inferiority. But totally agree with your observation on no differences in need for supplemental oxygen in days. And to come back to your time to full enteral feeding, there's a lot of debate on what you should do with enteral feeds when you give ibuprofen, and those randomized to ibuprofen. Some studies had the protocol that you would not increase feeds. So being randomized to ibuprofen would lead to a slower increasement of feeds, and thus an increased time till full enteral feeding. And maybe a short comment on acetaminophen. That was acetaminophen not with the intention to close the PDA. And I think that's so all indications were for other reasons than PDA closure. So could be post-operative after a neck procedure or discomfort, something like that. And I think that we really drilled the clinicians that they should not give open label treatment, that it also had its effects on acetaminophen exposure for other indications like discomfort or pain control.
Yeah, this is interesting. We have another journal club in May with Dr. Janssen on acetaminophen and its toxicity on PDA, so certainly one to look forward to. Paul, you can move ahead. Yeah.
Sounds good. I guess I'll point out the subgroup analysis as well. There seems to be an possible effect modification by sex and birth weight. As you can see here, is a breakdown of the incidence by the 5 different factors that were set out to look at subgroup analysis, and sex and birth weight stood out as potentially being a modifier. So I wonder if you can comment a little bit about those.
Yeah, I'm not aware of previous trials who looked at the sex differences. And if you look at prostaglandin pathways in male and female, there are some interesting studies on that. Of course, the autoimmunity diseases in adulthood and females, which are more common than in males. So there, might be differences in the response to prostaglandin inhibition within males compared to females, but I think it's really exploratory at the moment. But I would suggest that future trials really look at sex differences more, in more detail. And the birth weight, intrauterine growth restriction, you might have. That's something I hope Dr. Jens will also talk about. If you have a situation of growth restriction, then you have a lower glutathione storage, and you're not responding to oxidative stress. And it might be that after ibuprofen exposure with the vascular endothelial growth factor and things like that, you might be more prone to oxidative stress. So that's really preliminary, pre-clinical science at the moment. But I think there might be a signal too that the growth restricted babies aren't that well responding to anything we give them. Let's go.
Yeah, we've seen this a lot in animal models too, about big difference in how males behave in terms of lung disease compared to females. So certainly a topic to explore in the future. Yeah, Paul, you can move ahead.
Dr. Linkopan, who's been doing a lot of studies in this topic as well. So I think lastly, those all the data I want to present today. Just again, thank you for this research. I think this research data has really provided us with a really good data about expectant management in PDA in preterm infant. This seems to be non-inferior if we just look at universal treatment of PDAs just based on the size alone in terms of outcome of BPD, NEC, or death. Now, this I think is a debate about the potential risk of the disease versus the risk of the treatment itself. And this project has really shined a light on that. In terms of the pathogenesis, I know Dr. Hundscheid kind of highlighted this a little bit. Why is ibuprofen harmful? Well, it could be from the angiogenesis that is being inhibited by ibuprofen. I'm sure you can talk a bit more about that. Perhaps the acetaminophen has a similar process as well. So right now, based on this data, it seems to be safer to not treat with medications than do. So now this also does not talk about what about those babies with a more pathologic PDA shunt with a much higher shunt volume. We don't know if the treatment would be beneficial for those population. So that's data is to be published hopefully soon in a few years to another randomized control trial. But
So before we move to our final discussion and closing comments, I'm just going to launch a poll while we go through that and see what the audience thinks. Okay.
I guess while people are answering the poll, we can ask some of the questions from the chat. So I guess kind of to Paul's second point in his discussion and conclusion slide, there's a question in the chat about people speculating on the potential mechanism of injury to the preterm lung by giving an NSAID in the first week of life.
I wanted to comment. Paul had commented on the drug effect itself, and one other effect I've thought of, especially in the first week, is that the pulmonary pressures are elevated in babies early on. And could PDAs actually somehow be protective, and could that be a reason why they're less likely to close them, the sicker? Because we know babies that are sicker are more likely to have PDAs and have worse outcomes, but could somehow in a sicker baby with worse lung disease, could a PDA possibly be protective, and somehow closing that PDA early, could it actually be harmful somehow? So is it the actual drug, like a drug mechanism on the lung tissues, or is it something with actually the closing the PDA early? And I don't think we know that.
And I think I totally agree, Dr. Slaughter, that the neonatal death or the within 28 days was, somewhat higher in the group that received ibuprofen. So those who died in the ibuprofen group were all before 28 days of life. So that I think you highlight some important stuff there. And there's also some case reports on pulmonary hypertension induced by ibuprofen. So it might be a direct effect or a coincidental effect, because the angiogenesis hypothesis is really something on the long term. So for the BPD assessment at 36 weeks. And there's, I think, one study from, I think it was a Japanese group, in which they looked at biomarkers of vascular growth factors, hypoxia-induced factors, which were all influenced after ibuprofen treatment. but they intend to increase after the ibuprofen exposure once more. So it could be a badly timed exposure to ibuprofen, if that really causes the vasculature of the lungs to be that damaged. I'm not sure. It's I think as always multifactorial. But that's at least what we see in animal studies, and is also in some clinical data now on biomarker studies.
Maddie, you want to take the next question?
Yeah, sure. So it looks like the next question in the chat is for asking for comment about whether different timing of treatment. So instead of 3 days, using 7 or 14 days might have had different results, i.e. is potential harm associated with early treatment. It might not be there if you had treated later. The results might have been contaminated by babies whose PDAs might have closed spontaneously.
I totally agree. I think Paul nicely showed the graph in which the earlier you treat, the more benefit you will have from shunt exposure reduction, but the more adverse effects or the risk of adverse effects will be higher. So if you would treat at 7 or 10 days, which is also something we see from observational studies, that after a shunt exposure of 10 days or longer, then your risk for BPD is increased. And we're looking at subgroup analysis now on echocardiographic data. So really looking at those babies who have a high transductal shunt volume, if we only include those babies and then see if their outcome differs between expected management or early ibuprofen. Because I totally agree, there are some babies I know in the expected management, in the early ibuprofen group, which have a left to right, not a non-restrictive flow pattern, but a restrictive flow pattern. And I would never treat that baby with ibuprofen. So there is a contamination of babies who would have closed spontaneously, I think, and will not have benefit and might have harm.
That's a good question. I was just going to say the NRN PDA trial, I think the time to randomization, there's a window, but it seems like in that study, at least at one point, the randomization time point was happening not in the first week, but maybe second or third week. So it'll be interesting when those study results come out to sort of see, again, that's a study more of all comers with PDA instead of a more severe PDA. And so I think there's Suvik Mitra's trial, Smart PDA pilot trial. People are thinking of that, but there's a lot of, those are really good questions.
And in looking at the audience poll too, about 70% still prefer closing PDA between 8 to 20 days of life. Maddie, next question you want to take?
Yeah, the other thing I just wanted to comment about the poll results is that in typical fashion about anything associated with PDA, it's a 50% conservative approach versus 50% intervention that came up in our answers to current practice strategies. The next question is about whether there's a plan for follow-up on neurodevelopmental outcomes in these babies.
Yeah, there is. We presented the 24 months corrected age follow-up at the EAPS, so the European Academy of Pediatric Societies. And there we see no differences within the expected management group compared to the early ibuprofen group. And now we're trying to look at 5.5 years, which is the final follow-up we do in our national studies in the Netherlands. And I'm trying to get some funding for the school age, so 8 to 12 years cross-sectional, to also have a look at neurodevelopment, but also exercise tolerance and things like that, lung function. But we should receive a grant prior to really putting up this further research. So first results, no difference at 2 years corrected age.
So I can take the next question, which is probably combined with our fourth question too. So the question is, what was the percentage margin used for non-inferior non-inferiority and whether it was truly justified considering early termination?
Yeah, the non-inferiority margin was 10%. And I have to look at the data safety monitoring board chart in detail. But I think we said there that it would be 10% worse to treat the PDA. So, and we had a confidence interval of -7.9, if I'm correct. So, well.
Yeah, Dr. Slaughter, so is this the Vision Tesalis 2020 looking back, is this inferiority margin justified of 10%?
I think so. I mean, it's always a judgment call, but I think it makes sense to me, 10%.
So
I
the
wanted
final
to ask,
ahead.
still talking on the non-inferiority question, I noticed, Tim, at one point you said, had you expected harm, like potential for harm, you would have done a superiority analysis. I think this is not the first non-inferiority trial of the PDA, and also we're seeing lots of non-inferiority trials in neonatology. I think we're seeing more and more of them. And in general, it's interesting that what we're doing is we're taking a non-intervention arm, a conservative arm or whatever you want to call it, and treating that as the experimental group, right? We're trying to prove that something that we're already doing in practice is that we can stop doing it essentially. And that to me puts the burden of evidence, burden of proof on not intervening, as opposed to what I would typically think is like, if you want to say give a medication, you should prove that the medication helps. Whereas instead you're trying to prove that not giving the medication is not so bad. Just thoughts about that. Maybe a philosophical question more than anything, that like, should we keep doing non-inferiority trials for this, or really should we be sticking to saying, no, we need to prove that treatment is better, not that not treatment is not worse?
Yeah, I think that in the history of neonatology, we started to implement strategies without proper evidence at that time. So if you take the comparison to pediatric oncology, for example, there was nothing to treat leukemia, and then we thought of something, and then we add something, and we look, is it better or not? And then we try to reduce the morbidity by giving a lower dose of anthracyclines or things like that. And every patient is within a trial, and we're trying to look for the best package of treatment, rather than, because I don't think that only giving ibuprofen to a preterm infant below 28 weeks causes an increase of BPD of 17%. It cannot be only 3 days of ibuprofen that causes that much damage, I think. It's the associated, care we're giving and things like that. So maybe we should reconsider neonatology alongside the pediatric oncology and see if things we really want to do. So have a more conservative approach to a PDA, and compare it to the PDA should be closed with either medication or a cath closure. So do it more as a, how do you call it? Not only one question or one small question we want to answer, but really, is it the bundle? And it's also difficult because if you do a bundle, there's a reduction in IVH with bundles of IVH prevention, but now no baby is put on in prone position because of an increased risk of IVH, which I think is not proven at all. It's the bundle in which you prevent prone position. That's only one part of the bundle. So I think it's really difficult to answer this specific questions for, all the knowledge gaps we have. And I totally agree that it might not be non-inferiority trials we should do, but it should be more like platform-based trials in analogy to the pediatric oncology, if you would ask me. And it would also be much easier to recruit patients for it, because you're in a trial whenever you're diagnosed with a pediatric oncological disease. And if you're born preterm, you're also in the trial because, well, we want to get further as a community.
So I think
Ye-
yeah, one
Yeah, that's
comment I had is if you talk to the PDA believers, there's all this criticism that we're not selecting the right babies. There are some signaling studies that probably males or it's sex dependent or IOGR dependent, or maybe cath closure is a better option. So for all the young future trialists in our audience, what do you suggest they should focus on for future PDA studies?
I'll take that. I think one thing is trying to, if you can find the babies who are most likely to have, because of other PDA specific factors, and that's what we're trying to do with PDA prediction. And we're actually now we've got so many echo measures we've measured. We're trying to go through and tease out we're model building basically. So we're still working on that, but I think that's what we're trying to do with that data we did is trying to figure out, can we say which babies are higher risk because of PDA specific factors if you can adjust for other factors, clinical factors, lung factors, that sort of thing, respiratory severity, that sort of thing. And we're still working on that. We're actually just beginning our main analysis now. So hopefully we can figure that out. Maybe we won't, but I think that would be awesome if you could just try to pick the babies who are most likely to have where as Ronnie mentioned, that some babies are going to spontaneously close. If you could find the babies who are less likely to spontaneously close and are more likely to have a harm that seems to be PDA specific based on something on the echo, randomizing those babies. And then also, there's drug treatments, also catheter treatment, I think, as well, as something we're looking at in a study. In question there, I think, and I don't know, like that's where when I'm approaching parents, like honestly, I don't know if we should be catheter closing most of the babies we close on that. In the pivotal study, we have you have to have a higher severity of PDA and you have to be intubated. There are some secondary closure criteria for babies that don't get the cath, and those babies are actually have to be even sicker than that. And so I think, should pivotal find no difference, people are still going to say, well, hey, what about those babies that had end diastolic reversal flow and an increase in FiO2 that seems PDA specific? And so there's always going to be studies to be done. But I think like trying to pick the babies who are most likely to benefit. And I think we know that all PDAs don't need to be closed now. And it's trying to figure out which ones and closure timing.
So, I mean, it's certainly like congrats to Dr. Hundscheid for doing this study. Doing this at a PhD project, taking on this massive beast is certainly an accomplishment. And I'm sure the answer is not here yet, and a lot of studies for due. But the most important part of the poll we have is you did manage to change half of the people's approach to neonatology, which I think is very high. Neonatal is very hard to change until this very clear-cut study. So hats off for doing such an important study, and we look forward for further blockbuster studies from you. With that, I think we're almost out of time. There's some other questions which we can reply in an email chain or something. Thank you so much, Dr. Hundscheid, for coming. It was a pleasure having you here, and we hope to hear from you again soon. And again, Dr. Slaughter, I'm pretty sure we've not heard the last from you about PDA, so I'm pretty sure you'll join us again in a future PDA trial discussion. This topic's not going to end anytime soon. So thank you so much for valuable insight. And Paul, amazing presentation, very good. I learned a lot about PDA too from you. So thank you so much for this wonderful presentation. I'll see you all next time on March 19th for another Blockbuster Plus trial with Dr. Manley and Dr. Christy Waterberg. Another exciting topic to discuss. We'll hope to see you there. Just before, Dr. Hundscheid, do you have any closing comments for us? And then Dr. Slaughter to follow.
Once more, thanks for having me. And Paul, thank you very much for a nice presentation. Well done.
And I just wanted to say, great presentation, Paul, and Tim, wonderful study that you pulled off. And it's really hard to do trials in PDA because of prior biases and getting people to randomize and not cross over. That's an amazing work. And I think for the community, I think PDA studies are really important. So whatever your prior bias, if there's a PDA trial coming in the future to where you are and you can participate in, please participate, because as we've shown today, we don't have all the answers, and we sometimes get unexpected results from trials when we think we know what the answer could possibly be. And in this case, could there be harm with treatment? Things like that. I think we need more studies.
Yep. Well, thank you all. See you all next time.
Take care. Bye.